So looking at an adult data set, we compared our outcomes for both bone marrow and cord blood with Seattle. So this was a collaboration between Seattle and Minnesota. And shown here is the rates of relapse and the disease-free survival. And if you kind of just zero in on this blue line, you can see that double cord recipients have a lower rate of relapse than either a matched related, matched unrelated, or a mismatched unrelated patients who are here. And again, the disease-free survival is relatively similar because cords have slightly higher treatment-related mortality. So kind of moving over to the other type of transplant, haploidentical transplant. So the main obstacle to haploidentical transplant is T cells. So to do haplotransplant, you have to have about a 4 or 5 log reduction of removal of the T cells. And really the only way that you can do this is through the Clinimax device, which is through Miltenyi. And there are regulatory issues. In the US, this is still an investigational new drug. There are good manufacturing practices that have to be followed. Protocols need to be created, but it does lead to rapid neutrophil recovery. But these transplants are very expensive and difficult. But I wanted to talk about haplotransplant because this data, this is a relatively new series of experiments that the Johns Hopkins group has shown, which is basically T-cell replete haploidentical transplant, and then they give post-transplant Cytoxan. So this, again, is an incredibly bold experiment. This is a patient who comes to transplant. They receive relatively low doses of Cytoxan on the first 2 days. They receive a lot of fludarabine from days -6 to -2. They receive a single dose of total body irradiation, and then the parent or the sibling collects collects bone marrow, and then it's infused. On day 3 and day 4, high-dose Cytoxan, bone marrow transplant dose Cytoxan is given, and then GCSF is given. If it's a matched-related donor or an unrelated donor, if it's a matched-related donor, no GVH prophylaxis is used. And if it's a haploidentical donor, they use GVH prophylaxis. And what they think is happening is that the T cells are recognizing recipient cells. They start to proliferate and start to cause GVHD. And in their mouse models, this proliferation peaks at about day 3 and day 4. So when they give that Cytoxan, they kill all the cells that are proliferating. The cells that aren't proliferating, that won't cause graft versus host disease, just remain. And so this is pretty impressive, actually. Their rates of graft versus host disease are relatively low. They're about 50%, and their severe graft versus host disease is quite low. And this is with the sibling or the unrelated, and this is haploidentical results. And so recently we've compared our cord blood transplant outcomes to the post-transplant Cytoxan from Johns Hopkins. And what you can see here is this is the double cord and this is the haplotransplant. So this is in the black is relapse and in the red is non-relapse mortality. And you can see that the curves are about overlapping. So about 50% of the people will either die from complication or from their disease coming back. However, in the Hopkins data set, in the post-transplant Cytoxan, most of their relapses are most of their deaths are due to relapse, and that the treatment-related toxicity is very low. So this is very, very well-tolerated regimen. And if you look at the survival, again, the survival is relatively similar, although it does look like these relapses keep going. And so this has led to another randomized trial of cord blood versus post-transplant Cytoxan, which is currently open and enrolling patients in the US. So to be widely adopted, cord blood really has to be safer. As I already kind of alluded or mentioned, cord blood selection and the conditionings are nuanced, okay? The issues of non-engraftment are real and present. Immune reconstitution is delayed with all transplant and needs to be worked on, and relapses still do occur. So one of the things that some groups have tried to do is they've tried to substitute busulfan for total body irradiation. So most myeloablative regimens have used total body irradiation because of the relatively low cell doses and the high barriers to engraftment. However, this is an article by Sanz in Spain where he shows that the use of busulfan can replace the toxicity associated with total body irradiation. This is the cumulative incidence of neutrophil recovery. So as you can see, rapid neutrophil recovery in everybody engrafts. The other thing that the group in Chicago is doing, which is really quite amazing, is that they take a single cord blood unit and then they take a haploidentical CD34 selected peripheral blood product. And you can see here that now the median time to neutrophil recovery is about 10 days. And what's interesting is that if you look at the source of engraftment, the open bars are the CD34 cells. So early on, most of the cells are from the CD34 product, but then they drop down and then the cord blood takes over. And so it's the shift of chimerism. So again, will this replace double cord transplant? Potentially, we'll see what happens. Immune reconstitution is a major barrier of all transplantation. It's critical to success. And finding ways to make the recovery more rapid will have considerable impacts. And this is what I think a landmark study performed by Robbie Parkman on the COBALT data. So the COBALT data was the first national trial in the US looking at umbilical cord blood transplant recipients. And what this is showing is this is the probability of relapse. And the probability of relapse, and the two groups are, these patients here had a response to viral antigens. They had a response to HSV, CMV, or EBV. These patients didn't. And so if your immune system doesn't come back, you're more likely to relapse, is what this says. So again, getting the immune system to come back quicker is really important. Likewise, this is data from our center, a study that I led with Mike Burke, looking at lymphocyte recovery. So people who have rapid lymphocyte recovery at day 42 are more likely to be alive and in remission than people who have slow lymphocyte recovery. It's kind of scary because we also looked at day 28, day 21, and this was the most significant. But at all of these time points after transplant, you can look at somebody's lymphocyte count and you can predict with a reasonable likelihood who's going to live and who's not. It's pretty impressive data, actually. Again, back to immune reconstitution, this is data from an adult cohort from the Dana-Farber, and this is data from the Royal Free in a pediatric cohort. And this is looking at the T-cell recovery after transplant. This is the bone marrow patients who got bone marrow, and this is the cord blood patients. And these cord blood patients all got ATG, anti-thymocyte globulin. So you can see here early on after transplant, these people have almost no T cells. They're worse than most AIDS patients, frankly. And whether this is due to the ATG is not clear, but if you look at this cohort, again, this is pediatric patients and this is adult, but if you look at the cohort at 2 months after transplant, their lymphocyte, their T cell counts are really quite higher and even higher than the bone marrow. So whether the immune reconstitution is slower in cord is still not established. Can we create donors, or are donors equal in terms of their graft versus leukemia capacity? And I predict that genome-wide association studies will further identify donor traits that are linked to outcomes. And the question really is, can we create or can we identify super donors, donors that are less likely to be associated with relapse or less likely to cause GVH? And this